Right, afternoon, ladies and gentlemen. We're a bit constrained for time, so we'll kick off
Get up here.
straight away with the nightmare cases. Just a reminder that we'll have a brief discussion if we have time, but more importantly, at the end, you will help us choose a winner, and the winner will get registration as a form of punishment to come back to PICS next year. Hitesh Agarwal, yep. Transcatheter recanalization of chronic venous thrombosis. Hitesh.
7 minutes, Hitesh.
Thank you very much for letting me present my nightmare case. I'm a second-year cardiology fellow at Texas Children's. My patient was a 17-year-old male with multiple risk factors for thrombosis. He had end-stage renal disease and was on chronic hemodialysis. He had bilateral subclavian and innominate vein stenosis and also had possible SVC thrombosis. This is an angiogram. Patient had a right IJ hemodialysis catheter, which was exchanged for another sheath, and an injection shows that there is a fibrin sheath around the catheter. So given concerns for additional fresh thrombus, we went ahead and probed for a PFO and closed it with a 25 millimeter ASD occluder. Next, we obtained another axis higher up in the right IJ, and an angiogram shows that there is severe dilation of the right innominate vein. On the lateral projection, you can see better, there is severe stenosis of the SVC, and the right internal mammary vein is severely dilated, and it drains flow from the right innominate to the IVC. This angiogram shows that we are doing a peripheral hand injection from the right arm peripheral IV, and there is severe stenosis in the distal and proximal right subclavian vein. Likewise, you can also see there is stenosis in the proximal left subclavian vein. And interestingly, these are all under the first rib and clavicle, which is a component that you see in Paget-Schroeder syndrome. However, my patient also had multiple genetic risk factors for thrombosis, and he had an indwelling line, so his condition was much more severe. Next diagram shows our wire positions. Our first wire is coming out of the right IJ, and second one is coming out of the tunneled right IJ hemodialysis catheter. Third wire is in the right subclavian vein, and the fourth one is in the left subclavian vein. So we did serial angioplasties in all these veins, and the next slide shows you that there is some improved caliber of flow from the right innominate to SVC, but still a lot of collateral flow. So we decided to upsize, and we went from 16 millimeter balloons to up to 20 millimeter Atlas balloon, and we dilated the SVC and right innominate vein. Next angiogram shows there is much more improved caliber of flow from the right innominate to SVC, but at this point, we noticed that there was some extravasation of contrast into the pericardial space. And at the same time, patient also became hypotensive and tachycardic. So we quickly went in and we deployed, we inflated the 20 millimeter Atlas balloon to tamponade the bleeding site. At the same time, patient also received normal saline and epi boluses, and we quickly inserted a pericardial drain via subxiphoid approach under ultrasound guidance. Next, we quickly deployed a CP covered stent in the same area, but following deployment, we still see some extravasation of contrast into the pericardial space. And in the meanwhile, patient had drained about 500 ml of fluid from the pericardial drain, which was auto-transfused into the patient. And we went ahead and deployed another CP covered stent, and the bleeding finally stopped. So next we decided to deploy bifurcating stents, balloon expandable stents in the bilateral innominate veins, and self-expanding stents in the left subclavian vein. And angiogram shows that there is very good caliber of flow into the SVC from bilateral innominate veins. So we were pretty happy with our results. Patient went to the ICU, but over the next 3 days, he started to have increasing inotropic support, and basically his hematocrit kept going down. So we did a liver ultrasound, which showed a large subcapsular hematoma. So he came back to the cath lab, and this is an epilateral projection, which shows selective injection into the left hepatic artery. And as you can see better on the lateral view, there is a puff of smoke coursing superiorly in the left lobe of the liver. So we went ahead and coiled this with a platinum 018 coil. Next, we are withdrawing our pericardial drain over a wire, and contrast injection shows that there is a tract from the hepatic hematoma to the pericardial space. So we went ahead and deployed AVP2 to close this tract. Next injection, again in the left hepatic artery, shows that there is still some bleeding going on. So we deployed another 018 coil to stop this bleeding. And next angiogram does show that there is no further bleeding. So we were satisfied with these results, and also we inserted another pericardial drain via apical approach so that we could keep decompressing in case we were still producing a lot of pericardial fluid. At the same point, we also saw right pleural effusion, so we had to place a pleural drain, which drained about 500 ml of fluid. But 10 days later, patient came back to the cath lab, mainly for hemodialysis catheter malfunction. We had placed a hemodialysis catheter in the left groin during our first case, so that we could do CRRT during the case. So he came back to the cath lab for malfunction of the hemodialysis catheter. The catheter seemed to be working fine, and we did a venogram, which shows that there is good caliber of flow into the SVC from bilateral innominate veins. We repeated this venogram 6 months later, and we had the same result. So the patient has been doing very well. So just to summarize, it's always easier to recanalize acutely occluded vessels than chronic ones. The straightest approach improves your transmission of force to the penetrating guide wire. It's very important to use balloon inflation to temporarily stop bleeding whenever you have vessel tears. And we were very lucky that we had CP-covered stents available to us as a part of PARCS trial. And although rare, liver hematoma can develop with subxiphoid pericardial drain placement. And whenever results of your angioplasty is questionable, it's always better to proceed with stent placement. Thank you very much.
Ritesh, thank you very much for sticking to time. Very quick question. The hepatic artery bleeding, are you blaming the disease or the drain that was inserted, or what was the cause of that?
So we think it's both. First is the patient has multiple risk factors for genetic risk factors. And the second is our pericardial drain, although we did it under ultrasound guidance, it traversed the liver capsule. And the third is he had supratherapeutic INR because we had to be on heparin post-cath. So these are the three things that led to these hematoma.
But the bottom line is it's the operator fault, yes?
Yes.
Yeah, thank you. Okay, any other? Thank you.
Thank you.
Thank you very much.
Thank you.
Ritesh. We'll move on to Roberto Mijangos.
All right, I'll translate for Neil because he can't speak. So, you're not pressing the button on the microphone when you're doing it.
Oh, Roberto Mijangos. Aortic iatrogenic perforation during transeptal puncture. If anybody hasn't done this, this is a good way of doing coronary angiography from the venous side.
And he's not joking either, he's done it.
Good afternoon, everyone. Thank you, Mr. Chairman, dear colleagues. It is a true privilege to be here and to be sharing our nightmare case with all of you. We will present the case of a 48-year-old female with history of rheumatic mitral valve disease, for which she underwent mitral valve replacement when she was 31 years old. Oral anticoagulation was maintained with Coumadin. And then she presented with decline in her functional class along with jaundice and dyspnea 1 month prior to admission at our institution. On physical examination, one could appreciate the presence of a diastolic murmur in relation to mitral regurgitation, and on the other hand, both physical skin examination and laboratory findings supported the presence of acute hemolysis. Relevant radiographic findings include discrete cardiomegaly, and on electrocardiographic findings, the presence of left ventricular enlargement and some isolated premature ventricular contractions. So we performed a 3D transesophageal echocardiogram, and we can appreciate the presence of mitral regurgitation across the prosthetic valve and a paravalvular leak on the posterolateral aspect of the valve. So with all this in mind, the case was presented on our weekly cardiac surgical conference, and a decision was made to bring the patient to the cath lab to attempt the biseocclusion of the paravalvular leak. The procedure was performed under general anesthesia, fluoro, and under TEE guidance. Conventional protocol include the administration of prophylactic antibiotic, and the administration of standard IV heparin would be applied once transeptal access to the left atrium was achieved. So in this short axis view and this orthogonal X-plane view created by the machine, we can see the puncture needle engaging on the atrial septum. I am sure that many of you can notice that the needle was off target, approaching the septum in a parallel angle. Under fluoro, our impression was that the needle was tenting the atrial septum. We felt that the pigtail catheter was at a reasonable distance from the tip of the needle. So for such reason, we went ahead with the puncture. And this is where our nightmare began. We had perforated the aortic root, but more worrisome was the fact that the dilator was inside the aorta. The next video that I will show you is a recreation of our complication, and like I said, once the needle was pushed forward, our mistake was to advance the dilator before confirming adequate position of the needle. This increased the diameter of the perforation and prevented us from withdrawing it due to the increased risk of bleeding. So I think it is an understatement to say that all our faces look just like hers, but the important thing is that once the complication has been recognized, we start thinking on different ways on how to solve it. Luckily for us, the patient remained hemodynamically stable, heart rate and blood pressure were preserved, so the cardiac surgery team were notified immediately and had surgical backup if needed. Our solution, this is a recreation again, our solution consisted in advancing a 0.035 guide wire exchange length up to the ascending aorta, and then advancing the 8 French Moulins type sheath to the ascending aorta. Then we took both the dilator and the wire together, and then we loaded a 6/4 Amplatzer ductal occluder through the Moulin sheath and deployed it under fluoroscopy and TEE guidance, achieving a successful closure of the perforation. As you can see in these angiogram sequences, the closure of the aortic perforation. Once released, the echo showed the device in a stable position with no residual shunt around the device. So we consider this a problem solved. The next slides serve as a reminder of the importance of performing transeptal puncture safely, and here we stress the importance of having a complementary imaging to assess the site of the puncture. Again, we used echo guidance to perform the puncture, and now you can see an adequate engagement and tenting of the atrial septum and bubble confirmation upon entry into the left atrium when injecting the contrast to confirm position. In this angiogram sequence, you can see entry into the left atrium after our repeat puncture, and then how we ended up closing the paravalvular leak using NM Platzer vascular plug 3 uneventfully. You can see both devices. Again, 3D images show good position of the device for what we consider a successful closure of the paravalvular leak. At the end, we were so happy to call it a day, and finally, we all started breathing again. In conclusion, after a complete nightmare with a potential fatal consequences, we acted swiftly and found an appropriate solution for our patient. She was discharged 4 days later in adequate condition with improvement on her functional class, and currently, 6 months later, she is doing well with no complaints. Her echo showed no residual paravalvular leak and no leak across the device that we used for the aortic perforation. So I want to stop here, and I want to thank you all for your kind consideration.
Roberto, one quick question is, what were the coronary arteries like? We didn't see a good shot of those. Were they normal?
Can you repeat the question, please?
Coronary arteries, were they normal?
The coronary arteries are normal.
Because you could have done a selective angio. That's what Neil was trying to point out. And then, did you blame, because you got some fantastic 3D transesophageal echo pictures, did the imaging person not tell you that your needle was pointing not in the right direction, or you didn't believe him?
He wasn't sure about it. He thought that maybe the needle was not tenting the atrial septum, but I think that we were in excess of confidence.
Yeah, so it was his fault then, wasn't it? Not yours.
It
Yeah.
was our fault.
Yeah, okay.
But Roberto, next time you'll connect the pressure transducer to your needle, yeah?
Yes.
Thanks. Okay, great case.
Thank you.
Well
Thank you.
done. Okay, next presentation, Ape Divakar, inadvertent deployment of a fully expanded Diablo stent to treat atrial septal restriction. Did the catheter take as long as it does to read the title? Come on, Ape. Septal restriction in the left atrium after non-fenestrated Fontan procedure. Welcome.
All right, thank you, everyone. So this is a 6-year-old male who had hypoplastic left heart syndrome, aortic stenosis and mitral stenosis, status post Fontan procedure with a non-fenestrated extracardiac tube graft. More important than his history, his family had done some fundraising and actually had donated some funds to me, so we had a very good relationship.
How much?
Undisclosed. No, they actually had helped out quite a bit. So he developed, unfortunately, PLE, and he was initially started on steroids. He had significant improvement. Then he had some LPA stenosis, which was very borderline, but given his PLE, we decided to stent his LPA, which went smoothly. He then developed steroid refractory protein-losing enteropathy with edema, and everybody knows that that doesn't long-term go well, so he underwent further imaging, and he was found to have new atrial septal restriction by transthoracic echocardiography. So you can see there in the subxiphoid view, transthoracic echocardiogram, a high-velocity jet coming across the atrial septum. And that was new even after looking at his previous images. So at this point, I felt strongly that this patient should go to the operating room and undergo a resection of the septum and create a fenestration, mostly to avoid foreign material in the systemic venous atrium. We discussed a hybrid approach, and then we also discussed transcatheter approach, including a retrograde approach, transconduit, and then through the pulmonary artery. What was really happening was this. I tried to stay out of trouble. However, this always is in our mind. So we performed a hemodynamic cath. There was a 20 millimeter pressure in the Fontan circuit. There was a 6 millimeter pressure across the atrial septum. So initially we felt for a systemic right ventricle, we've pretty consistently been able to get across. So you'll see the pigtail there. You turn it around, make it en face. You get the glide wire to follow. Entered the atrial septum, the right atrium, from which we then crossed across the atrial septum into the left atrium and then a pulmonary vein. Okay. And this did not cause any hemodynamic compromise. Blood pressure stayed stable, saturation stayed stable. We took a 12 millimeter balloon and tried to just see what happened to the septum there. You can see it's easily stretchable and wasn't going to respond to balloon angioplasty alone. At this point, we were going to deploy a Diabolo stent from here. However, we had concerns about the sheath size in the artery. So we decided to take a picture of the conduit to see how we could perforate it. You can look there. See if the arrow comes in here. So one option was to perforate it in this area, given that the atrial septal restriction was there. We didn't want to be too high. And the second option was to poke just to the right of that neo-LPA stent and then enter from there. So we first tried to perforate through the conduit. Multiple attempts were made, could not get enough purchase, bent the needle tip fractured. Luckily, it was inside the dilator, or reasonably inside, and came out without embolization. So at this point, in our mind, we were not going to cross it, and this probably was a good time to quit. So then we decided to go from the roof of the atrium, and this is a very, in my mind at least, nerve-wracking procedure, the entire cardiac silhouette moving down. But we punctured across this portion fairly easily, eventually got in without too much trouble. You can see we left the wire into the pulmonary vein from the retrograde approach, still no hemodynamic compromise. So at this point, we decided to put a Diabolo stent. The way we do this is we take a oversized balloon, put a 5 millimeter snare in the middle of the balloon to create the Diabolo stent. Then we unmount or rather this was a unmounted stent to start. The next one was mounted. And then mount the stent on the snare so that the snare will restrict the opening so that you get the Diabolo configuration, and then you can always readjust the size of the waist to whatever size you need. So in this picture, as you will see, I was very confident that we were in the right position. We did have a TE probe, as you can see, and even on that, we felt that we were across the atrial septum. Okay, I think that went back one more. So then here's the Diabolo stent. You can see the snare in the middle. We deployed it on a 12 millimeter bib and created the Diabolo configuration. The stent keeps the waist in position. And even here, we were fairly convinced that we were in a good spot. So at this point, the picture is to show where we are, but before that, we realized that the stent was free-floating on the wire in the left atrium. And so we kind of, I have that sheath inside the stent just to keep it in position, and shot a picture, and you can see it's completely sitting in the native left atrium. And on the lateral, you can see we clearly missed the atrial septum. So now we have a fully deployed 12 millimeter stent distally, and we were debating on how we would cross this, whether we would come from the retrograde approach. As you can see, we were able to cross through the stent, then put a snare on top of it and try to capture it and pull it across, but then we were worried that we would get stuck on the atrial septum. The other possibility was obviously to send him to the operating room, but I don't think there was going to be any interest after giving it to us in the first place. So then at this point, we said one potential option would be to actually take a sizing balloon, which is much larger, put it on the stent, bring it, because it will be low pressure enough that we hopefully will not dilate the waist of the stent, and then inflate the distal end of this massively oversized sizing balloon, and then try to push the stent across, because the balloon would hopefully keep the septum or soft tissue away and allow the stent to go across and then deploy it. So that was the attempt there, and you'll see we think it was protecting it, and I know now that it was protecting it, and advance that stent across, and then we were able to dilate the waist up to 8 millimeters, at which point there was no residual gradient, and then completed the case. So luckily, did not end up under the train. So you can see that it's positioned in a Diabolo configuration, and his PLE completely resolved. This is just to show that we did create a fenestration, but prior to creating the fenestration, his fontan pressure dropped by 4 points just by putting the Diabolo stent across. And since this is a potential space, this is a cranially angulated view, we put a Diabolo stent using a covered stent, the atrium covered stent, since that's the only one we have available, again using a snare on the balloon. And here's the final angiogram of that procedure. So you can see there's a right to left shunt across the fenestration, and the atrial stent remained in a stable position. Wire was removed. Okay, somehow the last slide went, but he is in biochemical remission. His albumin is normal. It's been around 8 months now. Hopefully this will last for some time, and obviously we all know PLE can recur, and this is not necessarily a lasting solution.
Very nice, Ape. Very nice indeed. Double stents. Kissing stents almost. We'll go on then.
Yeah, okay.
Thank you, Ape.
Masood on femoral artery, Masood Sadiq from Lahore. Femoral artery tear, successful covered stent implant after coarctation of the aorta stenting. Masood.
Chairpersons, ladies and gentlemen, for those of you who don't know where Pakistan is, that's where I come from. It borders Iran and Afghanistan. It also borders China and India. This was an interventional workshop which was organized by one of the centers close to Lahore in Multan, and I was the pediatric cardiologist who was called for training local cardiologists how to stent coarctations. This was a 24-year-old woman with systemic hypertension for many years, and diagnosis of coarctation was only suspected at first delivery of that woman, when one of the residents who had recently passed MBBS actually felt the femoral pulses and couldn't feel it. Echo confirmed the diagnosis with LVH and bicuspid aortic valve, and she was scheduled for stenting in this particular workshop. You can see what I can see over here as well. This is a severe coarctation of aorta with origin of the right innominate artery just above the coarctation segment, but it was a very severe coarctation. We followed the usual protocol of general anesthesia. We accessed the right femoral artery, femoral vein for RV pacing, and we gave heparin to the patient. Which stent to put in? Because this is a child, this is a patient who has a right subclavian right brachial arising from just above the coarctation segment. Would you go for a covered stent? We asked ourselves, or bare metal stent, and then in bare metal, we had the choice of either going for a CP or a open cell design. We went ahead with a 12 French Mullins sheath placed over a super stiff wire, and we decided to put in a open cell design EV3 stent, and which was crimped onto a bib balloon. This was a 8/16 bib balloon. As you can see, we positioned that this was a rather low position, so we went ahead and improved that position, and then we inflated the inner balloon with RV pacing, as you can see over here. This is the inner balloon, stent on that inner balloon, and then we thought we had a very good result and expanded the outer balloon to our expectation. This is angiograms, both in AP and lateral view after the procedure. There was no gradient, residual gradient, good flow across the right brachial, and we thought we had a very good hemodynamic and angiographic result. Back home, we do manual compression because we can't afford all those devices which you use. The patient was extubated and being monitored in recovery. The fellow who was compressing the groin soon noticed that she was developing tachycardia and a change in patient's outlook. Peripheries started getting cold, and that anxious look started going into a deteriorating conscious level. So we all left T and ran towards the patient, who was reintubated and immediately taken back to cath lab. We resuscitated with blood and fluids, and the cardiac surgeons were alerted. What had gone wrong? A lot of thoughts came into our mind. Could this be a dissection or a rupture after we had done it? Could it be a femoral artery tear? Or an intracranial event has occurred which has actually caused this severe deterioration? Anyhow, soon it became apparent that actually right lower abdomen was getting distended and there was a retroperitoneal hematoma. We went ahead with left femoral artery puncture, which was nightmare at that point with 20 plus people on your head, including an adult cardiac surgeon. But what sort of really put me in trouble was that I was told by the cardiologist that she's daughter of the city police officer, so you better behave. The moment I heard police, I thought it was going to be an American police, which is what you see most of the times as we Pakistanis once we enter into US.
I would have caught the first helicopter out of the city.
Right. Fortunately, I had my chief technician with me, who always has this Taliban scarf. I always take him with me, just in case I need him. And I had alerted him that I might need you. So we went ahead, did an aortogram, which clearly showed that the stent was in position. There was no dissection, there was no aneurysm, and I think that's the protocol which we had to follow. But immediately that, you can see I gave an injection from the top going from the left side, and we could see there was actually a clear-cut femoral artery tear, which was not very far from the groin where he was compressing upon. And that was the reason for this hemodynamic compromise. What would you do now? We were not getting into the right femoral artery at that time, but fortunately we did get in, and the moment we gave that injection, you could see already there was a big hematoma over there. So what are the options? I think we didn't have many options because whenever I go to a workshop, I always take covered stents with me. And that's what I did in this particular time as well. You can see we placed a covered stent across that tear, checked it, made sure that it was at the appropriate position, and then inflated it with an appropriate size balloon. This was the final result you can see, which looked excellent. There was no residual bleeding. It was perfectly in position and actually was of appropriate size too. She needed in total 3 blood transfusions. She was electively ventilated overnight, but she walked out of the hospital 48 hours later with very good Doppler flow in the right lower leg. So what was the moral of the story? I think never stent decoarctation if she's the daughter of a police chief, unless you have enough covered stents. And I think that's the real moral of the story. While I was doing this case, I thought about the American police, but I also thought about German police because I was stopped once in Germany too. I thought the Britishers were more friendly with me because I was trained there. By the time we finished the case, it was already raining. And as I moved out of the institution, this was the Pakistani police. So I didn't have to be scared at the end. Thank you very much.
So, Masood, what do you think caused the tear in the first place? The guy pressing on the groin afterwards, pressing too hard?
No, I think it was when the sheath was taken out. It was pulled out, and I was told subsequently that when the sheath was being pulled out, he had to put some pressure to pull it out towards the terminal event. And I think that's where he abraded the femoral.
So the sheath, there must have been some spasm around the sheath that was making it tight. Okay.
Because it was a tight fit, yeah.
Yeah, okay. All right, thank you very much.
Thank
we'll
you.
move on for interest of time. Thank you, Masood.
Hojat Motazayan? Hojat? Let's go. Nightmare in RVOT stenting, flying stent and lucky patient. Not a lucky doctor, or?
Thank you, everybody. It's my pleasure to present some of my trouble case in the CAT lab while the RVOT stenting. I'm working in Iran. I labeled this case flying stent and lucky patient.
Hujat, for the interest of Americans, you didn't show a map of Iran just to show where Iran is.
I don't have any map or any show
Okay.
from the Iran, but Iran is near to Pakistan. A boy, 5 months old and 4.5 kilogram in the weight, with severe cyanosis, recurrent spells, TOF anatomy with small PA branches, PO2 near 35 millimeter mercury, and O2 saturation lower than 65%. Primary diagnosed by the echocardiography in this patient is TOF anatomy with small PA branches. We scheduled this patient for the catheterization and RVOT stenting. In the first view, you see injection in the RV, a small PA branch, right aortic arch, and severe RVOT hypertrophy. In another injection in lateral view, you see a significant RVOT stenosis. We try for RVOT stenting without use of the guiding catheter because patient was very unstable, hypoxic, and very suitable for the arrhythmia while they pushing the guiding catheter. We used a 6 by 18 millimeter pre-mounted stent, Blue Genesis stent from the Cordis company, for the RVOT stenting. In this view, you see inflation of the balloon and good position of the stent in the RVOT without using any guiding catheter. After inflation and deflation of the balloon, we cannot remove the balloon. While the remove of the balloon on the guide wire, we see balloon and stent connected together, and we cannot remove the balloon. While this manner, we cannot remove the balloon, and after many trying and many attempts for the remove of the balloon, unfortunately, stent and balloon pull back to RV body together. In this view, you see balloon and stent connected together, and we cannot remove the balloon. But after so many try, finally balloon detached from the stent, and balloon pull back to IVC. Here. Because O2 saturation of the patient is very low and blood pressure is to be low, we tried for pushing the balloon from the unstable stent for just valvoplasty of the pulmonic valve. In this view, you see a significant indentation and stenosis inside of the middle part of the balloon. We pull back the balloon, and after so many try, in some times, and you see a better position of the balloon and better remove of the indentation via the stenotic pulmonic valve. After this time, we decided to put another stent, same size with the first stent, for the fixation of the first stent in the RVOT. We entered another stent, same size, 6 by 8 millimeter, from the first stent, and after putting the second stent in the RVOT, we inflate second stent, and we thought it's possible we fix the first stent by this technique, by the telescopic method. But after, but unfortunately, after injection, you see bad position of two stents. First and two stents pull back to RV body. After many minutes, we saw the proximal part of the first stent is fractured, and we have a significant fracture and displacement and angulation between first part and second part of two stent. In this view, you see proximal part of the stent fractured and displacement with significant malalignment. Unfortunately, we thought it's better removed our guide wire and referred this patient to urgent operating room for the mid-sternotomy, central shunt, and the removal of two stents from the RV. After removal of the guide wire, in this view, you see position of the stent is fixed, blood pressure is good, and O2 saturation is near 60 up to 70%. But after many minutes, there is not the big part of a stent in the RV body, and just we see a small part of the stent in proximal part. Big part of a stent embolized from via the VSD in the descending aorta in upper part of the renal artery. In this injection, you see position of the stent higher than the renal artery in the descending aorta. In this time, we decide to implant another stent with a diameter of 6 millimeter and length of 24 millimeter in the RVOT and main PA for better stability and better hemodynamic position for the patient. We used 6 by 24 millimeter stent in the RVOT and proximal part of the main PA. This stent is express stent, is pre-mounted peripheral stent. After stenting of the RVOT, you see a good position of the stent, good filling of the pulmonary artery, and hemodynamic of patient in this time is better than. But you see a small part of the stent in the RV body. After removal of the guide wire, after successful stenting, you see a small part of a stent in RV body is very jumping. And after many times, after many minutes, another part embolized to descending aorta connected to another part of the stent, and everything is good for flaring. And finally, we try for flaring of the proximal part of the stent in the diaphragmatic level, and after fixation of the stent in the diaphragmatic level, we patient referred to the ICU, and after 3 months later, you see a good position of the stent in the RVOT and main PA, better growth of the PA branches, And finally, you see a position of the stent in the descending artery position, good distance from the stent between a stent and bilateral renal artery, and good filling of the descending artery, descending aorta and abdominal aorta. Finally, our planning for this patient is refer of this patient for the TF total correction. And what is one question for us? What is the best method? What is the best protocol for the descending aorta stenting after 5 or 10 years later? Thank you so much.
Thank you, Hujat.
Hujat, Huwaida, quick question.
No, I was going to answer his question.
Oh, right, go on.
So I think, the stents you put are not going to go to adult size. So you're going to have to break them at some point. So I don't know what kind of stent you used, but I think with time you would inflate them to their maximum inflatable diameter. Before you reach that diameter, you're going to want to put another stent in and then use a high-pressure balloon like an Atlas balloon and break it. I think it's safer to do that once you put another stent in it to stabilize it, and then you can fracture it.
Yes,
Okay.
all right.
Hujat, quick question before you go. So the first time you put the stent in, you went without a sheath, just over a wire.
Yes.
You had no idea where the infundibulum was. You inflated it and the stent migrated.
Yes.
The second time, you went in without a sheath, without an angiogram.
Okay.
You had no
Okay.
idea where the infundibulum was.
Okay,
Yeah?
you are right.
Is that fair, or
Okay,
am I being
you are
unfair?
right. But we have just a
And then I was going to say the
14
third time.
Okay, no, we have just a 14-inch guide wire, a coronary guide wire inside of the stent. If we want to use a guiding catheter and putting the guiding catheter via just a coronary guide wire, it's possible we lose our guide wire while this manner.
But nature has done quite a good job for us, because nature has given you a second femoral vein.
Yes, it's good.
Yeah? Okay.
Thanks, Hujat.
Thank you very much, Hujat.
Thank you. Thank you.
Neil, what? Were you there?
Promise not. I wanted to know if the patient in any way was related to anyone in the Iranian police force. We'll move on now with Siva Kumar from Chennai, who's going to talk about a whole series of hemodynamic and interventional complications during pulmonary valvotomy and device closure of a VSD. Welcome, Siva.
Thank you. Take the opportunity for all these nightmares to just teach us certain. Take an opportunity for all these nightmare presentations to teach us a little bit more. My patient is a 15-year-old girl who had central cyanosis, who had an oligemic lung fields and a smaller heart. The basic anatomy was a 10 millimeter anterior muscular ventricular septal defect with a right-left shunt, severe valvular pulmonary stenosis with an annulus of around 16 millimeter. The right ventricular infundibulum was opening well in diastole, so we thought that valve is amenable for a valvuloplasty with a suprasystemic RV systolic pressure. The hemodynamics are the right ventricular pressure was about 40 millimeters more than the systemic pressures, and the pulmonary artery was 24. RV angiogram showed doming valve with a very dynamic infundibulum. We can see that it opens well in diastole. We did a balloon dilatation. The right ventricular outflow tract gradient came down from 112 to 60. RVSP became systemic, PA systolic, marginally improved. The dynamic infundibulum protected the distal pulmonary arteries. The saturation shot up to 100%. And the VSD was shunting entirely left-right. So our plan was to go ahead with the VSD closure. We did an LV angiogram. We found a moderate-sized mid-muscular ventricular septal defect, which measured about 10 to 10.5 millimeters. We had two options. One was to use a muscular VSD device, or sometimes in these patients, we also use an ADO1. Now, we may have a question about how an ADO1 can be used because it doesn't have a RV retention skirt, but when we try to choose a larger ADO1, and when that is being compressed on the center by the muscle, the ADO1 also behaves like a muscular VSD device. And so we decided to use a 1614 ADO1, which is available outside the United States. And this is a 1614 ADO1. And on the LV angiogram, the aortic retention skirt seems to be well flush. And the right ventricular pressure, the moment the device was in, the right ventricular pressure dropped down to 65, proving the fact that the VSD was also possibly contributing for the higher RVSPs. But the moment we released, the device sort of slipped more towards the left ventricle, was not truly embolized. We made an LV angiogram. We found that the device was far too much within the left ventricle, with just barely being held by some parts of the ventricular septum. So we decided to snare it out. So it was caught with a 25 millimeter snare. And once the snare hooked around the device became smaller, so it could easily be pulled out through the left ventricular outflow tract. It came into the descending thoracic aorta. And once it was in the descending thoracic aorta, the screw end was facing inferiorly. So cable was reintroduced through the arterial sheath, and the device was re-screwed in. And we could take it out through a 7 French sheath. And we decided to go for an 18 millimeter muscular VSD device. On the LV angiogram, the device looked quite tilted, extremely tilted. And it looked like the left ventricular disc was not correctly placed at all. However, when we made an angio from the right ventricle, it looked as if the RV disc was in good position. Remember, this is very, very anterior muscular VSD, and so actually we were not getting a correct angulation for viewing the surface of the left ventricle properly. And then we decided to...
This is a very reassuring tea. This is a very reassuring tea.
Yeah, it's actually, my assistant is telling me it's very reassuring. So it looked really reassuring on the echocardiogram, and so we decided to release. The moment we released, the LV angiogram showed that the device was too much tilted, and we didn't know what to do because on echo it looked good. We sent the patient to the ward. The child was fine. The next day morning, the child was walking around in the ward. We went for rounds, and we found that there were a lot of ectopics. We rushed the child to the lab, and we found that the device was in the left ventricular outflow tract. So we took the patient again into the lab. We put in a snare catheter into the left ventricle in order to snare it out. We went into a complete heart block. The snare catheter was scraping the bundle of his on the left ventricular outflow tract, and the child had no pulse. And so immediately resuscitation was done, a pacing catheter was introduced, the hemodynamic got stable, and then we snared it out with a large snare. We got it down, but this time we couldn't get the screw end facing inferiorly. So we got it down all the way up to the iliac artery, and we realized that this 18 millimeter muscular VSD is possibly too large to be taken through any sort of sheath in the groin. So we decided to go with a strategy of going and re-screwing the device. So this time we took a brachial puncture with a 5 French and advanced duct occluder cable, and the cable went all the way down, and we are now screwing the cable back into the device. And once we got the screw secure, we pulled it back into the descending thoracic aorta, which had a slightly larger space. And the intention was still to take it out through the femoral artery, and so we snared the other end, the non-screw end. And once we got the non-screw end tightened, we got it down through a 9 French femoral arterial sheath. Because we are holding from both the ends, we slenderized the device and tried to manage this 18 millimeter muscular VSD device to get into the 9 French femoral arterial sheath. So the device comes out through the sheath. Now it's actually, it walks in through the sheath now. And once the entire device comes out, we make a check angiogram on the iliac artery to see what sort of damage it has done. And we are finding that there is not much of flow. You can also appreciate here a sort of thrombus, a small sort of thrombus just above the sheath. So we thought it may be, prudent to pull out the sheath. And now echocardiogram was repeated. It's a 10 to 11 millimeter ventricular defect, shunting left-right, a dynamic infundibulum of peak gradient of 65. The saturations were full. Previously, it was a cyanotic child. The hemodynamics was pulmonary artery had a pressure of 35, RV had a pressure of 90, aorta 100. The child was shifted into the ICU in sinus rhythm. Now the heart block has recovered. The temporary pacing wire was off. Now starts a large drama in the ICU. The BP drops to 80 millimeters. The saturation drops to 92%. There was a fear about whether the VSD is overflowing, whether there is pulmonary edema, and is that the reason for the 92% saturation? So a large dose of furosemide is given and dopamine was started. There is further drop in the blood pressure. The BP drops to 50, the saturation drops to 70, hemoglobin 8 grams. So more and more dopamine added, epinephrine added. The BP drops further, the BP crashes to 30, saturation drops to 30, pH is 6.2, lactates are very high, hemoglobin is 4 gram. Very quick worsening over a period of 3 to 4 hours. We do an echocardiogram, a hypercontractile ventricle on dopamine and epinephrine. VSD is totally shunting right to left, a small underfilled right ventricle, right iliac fossa showed a hematoma above the inguinal ligament. If you remember, we did not get a proper flow, and so we were not able to appreciate that there was a vascular injury. We thought it may be a clot with some spasm. But then when we reviewed the pictures, we realized that there was a large device at the proximal end of the iliac artery, and so there is a possibility that there could have been a bleed. So immediately the strategy was changed, Paxils were rushed in, fluid was rushed in, dopamine and adrenaline was abruptly stopped, and phenylephrine was started. We started managing like a tetralogy spell. The hemodynamic immediately normalized within 2 hours. The hemoglobin improves to 9.8, pH improves to 7.3, blood pressure normalizes, saturation becomes normal. Now we decided to chase the VSD quickly because the VSD was shunting, sometimes left-right, sometimes right-left. So we this time decided to use a 24 millimeter muscular VSD through the right internal jugular. And once we got the device in position, the right ventricle was forming consistently a cobra. It's not forming properly at all. There was a wishful thinking that if you release the cable, sometimes the device will regain its memory, but having embolized 2 devices and having snared 2 devices, we decided that's not a good option. We started thinking why this right ventricle disc is forming the cobra deformity. Basically, if you see, this is an anterior muscular ventricular septal defect, and we are coming from the tricuspid valve with a jugular catheter, and the RV disc is not having a proper opportunity to form itself at all. And the more and more we push the cable gets pushed towards the right ventricular apex and actually tilts the screw end more towards the apex and dislodging the VSD from the device from the VSD. And so we decided that's not the correct strategy. So we decided to go this way. We again recrossed the ventricular septal defect and got the sheath up in the ascending aorta, and we decided to snare the tip of the device from the ascending aorta so that we could have a control of the device from both the ends. And now holding the non-screw end, now we have a control from both the end and gently shuffle across the large device, across the ventricular septal defect. And so we are holding the device here from the left side through the snare and right side with the cable, and we could get the device without any cobra. And that brought the device to its correct memory, and post-device the angiogram was stable. 2-year follow-up, girl is healthy, no residual VSD, infundibular gradient of only 20 millimeters of mercury. So what did this patient teach us? It told a lot about what sort of device we should be selecting for muscular ventricular septal defect. It told us how to respect an iliac arterial injury. It informed us that all hypotensions in the ICU should not be managed just blindly with inotropes, and sometimes we can have a very frank tetralogy spell even in the presence of a moderately restrictive ventricular septal defect. It gave us an opportunity to try out varieties of methods of snaring devices and slenderizing devices, and we it told us how we can grossly over or underestimate VSD sizes. And not all device deformities are just due to abnormal memory. It may be due to abnormal position of the right ventricle that doesn't allow the device to fully form. Thank you.
Shiva, just again, another take-home message, and that is you retrieve the device that embolized down into the iliac artery without a sheath higher up. You've got a sheath in the femoral artery, yes?
Yeah, we had a.
And it's a big device that you're trying to pull through back into the sheath. So isn't that one of the more important messages, that if you're retrieving a device...
Probably the sheet should have been long enough to enter into the abdominal aorta rather than... Yeah. I think that's another message.
Okay, oh, Basil.
I think that a bad day starts in the morning. So...
Basil, a bit nearer the microphone.
Yeah. A bad day always starts in the morning, at the beginning of the day. I think there were two things that they are not done well. First, I think that you didn't size the device well, and if you are in doubt about the size of the device, you should do balloon sizing. And second, I think you should go to Nasik to watch a guy there who is using the ADO, closing VSDs using the ADO one. I was there doing proctoring for Cocoon, and I learned from him, and I've done 2 cases with the ADO one. Before you release the ADO one, you should see the device very well compressed. The first time when you releasing the ADO one, there was no compression of the device at all.
But
Thank
probably
you, Basil.
more important message is the use of an ADO1 type of device in a muscular VSD, whether that's a good idea or not.
We have used it on a large number of occasions in the past, but these are things that taught us that probably that is not the appropriate device.
Good lesson.
Thank you.
Thank you, Siva. Nice case.
Okay, I think we're on to the last case. Mai, where are you, Mai Al Sayed? Coming up. Yeah, there we are. And that's turning brown to yellow. And I'm trying to work out what it is that we're trying to turn brown to yellow. I can only think of bicycle clips at the moment.
Thanks, Jack, and thanks for accepting the nightmare case, my nightmare case. It's a little nightmare compared to the previous ones. I especially like the ones with the flying stents. I mean, this was really a nightmare. Well, our story starts with a workshop. We were doing a VSD workshop of 6 cases. We were using the PFM coil. We had very complex aneurysmatic VSDs. 4 of them were very large. We had to reposition the coil several times until we got a good position. And 2 of them were quite straightforward cases. One of these cases was a 60-year-old girl with 24 kilograms. She had a small VSD with an aneurysm. She was relatively asymptomatic. She had repeated chest infections, but her LV was slightly dilated by echo. And the parents were very anxious, and they wanted the VSD to be closed because they didn't want the murmur anymore. We tried to convince them, but they really wanted the VSD closed, so we thought it's a small VSD, might as well do it with a small coil. And we did. It was a small aneurysmatic VSD, small aneurysm, small pouch there. And it took an 8/6 coil. It was a very straightforward procedure. It took only 30 minutes from including the snare, the loop, everything. And we had complete closure of the VSD. Although we did not like the position of the coil very much, but I mean, it was there, and echo showed no residual defect, and angiography showed no residual flow. Well, next day, the girl was fine with well-felt peripheral pulses and was discharged on aspirin 5 milligram per kg and antibiotics. She was doing extremely well. And 48 hours later, the resident called and reported that the girl, mom called and reported dark urine. And I told him, please bring her back to hospital. She was brought back to hospital at night, and the resident examined the urine and said it was just concentrated urine and was about to send her home. So I said, could I see a urine sample? He was not very happy about me saying I needed to see a urine sample. I said, please just photograph the urine sample and send it by WhatsApp or whatever. This is what he did, and this is the color of urine. He thought this was concentrated urine. So I thought, of course, the girl
Your resident didn't say, if you want to see the urine, come in and see it for yourself.
No. He sent it over. No.
Okay.
No, he wasn't very happy of doing that, but he did that. Anyway, I said just throw some samples, blood samples and urine sample and see what we find. So her initial blood picture showed an hemoglobin of 9.4. She had some corrected critics were not much, 1.7%, normal up to 2.5%. Apparently the resident has called the lab and made a deal with them because the urine sample said dark yellow. It did not say anything about brown, it said dark yellow. It said it was a deep yellowish urine. It didn't say anything about brown. And it has a few bile pigments, few bile, nothing specific. Next day, sample of blood showed that dropping of the hemoglobin. The hemoglobin kept on dropping, and I thought that the urine still looked very, very, very dark, although they all said that it was concentrated, and this was obviously a case of hemolysis. We did not expect this girl. We expected two other patients, because in the two other patients we had residual VSDs, and we were expecting hemolysis, but not in this one. So obviously it was hemolysis, so we decided to weigh our options. Echo showed the residual VSD. I mean, some flow coming off near the coil here, and some flow coming off across the coil here. And the problem with the coils is that they do a lot of reverberation that you can't really see where your defect is. So what were our options? One option was to go to surgery and exteriorate the coil, which we did not like very much. Another thing was to snare the coil out and try and put a larger coil or another defect. And the third was to close the residual defect with another coil or a device, preferably even an AV2 or a vascular plug 2, depending on what we're going to find. So it took the patient to the cath lab the next day. And as you can see, this is the second cardiac catheterization. And the coil has just flipped, has done some acrobats and flipped. And now it is attached to the tricuspid valve. It's not in the pouch anymore. And we could not really see the boundaries of the VSD or where. We did some measurement then, and we found that there is from the coil to the VSD or to the left ventricle 7 millimeters. And the size of the defect was about 5 millimeters. So at that point, we thought snaring was not an option, because if we snared on the coil, it's going to pull on the tricuspid valve tensor apparatus, and it's going to cause a lot of problems. And I had a previous experience with something like this with a piece of a catheter hanging on the tricuspid valve, and we ended up with complete heart block, not tear in the tricuspid valve, but extreme tension on the subvalvular apparatus would cause heart blocks. So we started with a Judkin right catheter. We thought we'll put another device in, and we said we wanted something to be put from the left side, because if we were scared if we put the coil, that the coil would just migrate. Fortunately, it did not at that stage. And then we decided to have another femoral axis and try and see where the defect is, because this catheter was going down here, and we would put another catheter there. We found that the flow is going up to the right ventricular outflow tract. So we decided to pass another wire across, because we thought these were two defects, or two distinct defects, and the echo showed so. So now we had one catheter in the right ventricular outflow tract and one catheter in the RV body, and we were not sure what to do next. So we thought, no, TEE was needed. Now we needed to see what is going on. TEE did not show us much, because we just showed that there is the VSD there, and these are the wires in place. It just showed us that we had two distinct catheters, one in the right ventricular outflow tract and one in the RV body, but we could not see where exactly is the defect. So we decided to go for the one going up to the right ventricular outflow tract, and maybe put a vascular plug too, in order to sandwich the whole coil in and not leave any residual flow, because we wanted to close it completely from the left ventricular side. And this is what we did. We removed the first catheter, left the wire hanging in the right ventricular outflow tract in, and on the way removing it, you see the coil kept on moving and swirling around, but it did not embolize, fortunately. This was very lucky for the patient. And we replaced this with a Judkin Wright guiding catheter, and we were doing this, the coil kept changing position, and now we had a VSD of 6 millimeter instead of a 3-4 millimeter. So we decided on a vascular plug 10 millimeter. It had a distance of 7 millimeters, so we were safe there because this was the original measurement we've done. We put in a vascular plug 2, guided both by TEE and by angiography. There is the disc. We tried to put the body of the plug itself inside the aneurysm and the disc. At first, we were not very successful, and we did have some parts of the device hanging in the aorta with some aortic regurgitation there. But finally, we could put it right. We had to make sure that we had no tricuspid regurgitation, and we did not have any. And this is the final, after we just placed it well, released the plug, and we had no residual flow and no aortic regurgitation. On the second day, we were also worried about RVOT. Now it changed from brown to dark brown and to yellow. And this is for you, Shaq, why it's changing brown from yellow. So what are the take-home messages here? Next day, of course, everything was fine and no TR. Take-home messages that mechanical hemolysis is a complication of surgical and interventional procedures. It was first reported actually by my father in 1961, where they were closing an ostium primum ASD and a mitral regurgitation, and the patient ended up in hemolysis and didn't know what was going wrong. The patient stayed in hemolysis for 6 months until they decided that maybe the surgery was the problem. They went back in and they found the Teflon patch was not covered, so they covered this up and repaired the mitral valve, and the hemolysis stopped. So I was always minded, he always told me the story, I was always minded that if I'm going to do interventions, I have to look for hemolysis and be aware of them. The other take-home message is potential complication, given the potential complications of VSD closures, and there are no ideal VSD device yet. We've seen complications with a lot of devices in the previous talks. I think small VSDs should be left alone and just followed up, and if we're scared of endocarditis, we can just give them prophylaxis against endocarditis, and we're done. And thank you.
Mike, thank you very much. Probably the most, well, not probably, the most important message is that last one, is it not? Because it was very difficult to see the VSD before coil occlusion in your angiograms, and it was obviously much bigger afterwards and caused the problem.
That's correct. Yeah.
Okay, all right, thank you very much, Mai. Let's move on. And now, in the next few minutes, we're going to have to decide, and you're going to help us choose the winner, and the winner will get the registration free for next year's PICS meeting, or next PICS meeting, which will be in Miami, I think. Is that right, Z? Next PICS meeting in Miami, yeah? Okay, so what we'll do is, as we traditionally do, your intensity of clapping will help us determine the winner of this. So if I start with the first presentation, we've had some fantastic presentations, and it always takes a lot of courage to stand up here and show each operator's incompetence. And then be the winner of highly incompetent complication. So the first incompetent operator was Hitesh Agarwal, who tried to blame the Paget-Schroeder syndrome for tearing the hepatic artery and causing the capsular hematoma over the liver, whereas it was the operator, of course. So big round of applause if you think he should be the winner.
Okay, next is coronary angiography from the venous approach, particularly using transeptal puncture into the aorta whilst not using a transducer. That is Roberto Miangos. Roberto.
Okay, right. Let us get this right. It's the intensity and volume of clapping, not the cheering, that will determine the winner.
No, we like cheering. Cheering's fine, Jack.
Oh,
Cheering's fine.
Okay. Next one was the Diablo stent that was implanted in the left atrium and certainly not across the atrial septum, in whom the family had raised a lot of money, and I'm not sure if they asked for the money back after the intervention, and that was Abe Divakar.
Abe.
Go on then.
The moment you've all been waiting for. Oh, no. No, it's not the moment we've all been waiting for. Masood had a marvelous femoral artery tear and managed to cover that with a covered stent in the daughter of the chief of police of Multan. Particularly good.
And the next one,
What can
I'm
we
trying
say?
to work out what levels of incompetence there might be. And this was a case where there was no injection to tell you where the stent should be implanted, but it was implanted, and the stent has a mind of its own because it doesn't know where to stay, so it sort of migrates to the right ventricle, and then it decides to migrate to the aorta. Then another stent without an angiogram, and then the stent decides to break, and then another stent without an angiogram, and so it goes on, and then the stents have their mind of their own because they join up because they felt so lonely. So they join up in the descending aorta. And eventually, we managed to get a good result. Go on there.
I think on a scale of 1 to 10, Hajat, this definitely scores 12.
So, big hand.
Siva, you showed us and taught us a great series of hemodynamic and interventional complications, particularly that one of perseverance, in that if one complication is not enough, then why not have another one? And if that's not enough, have a third, and maybe a fourth. Anyway, Siva, a great display of intuition, let's say, and bravery showing us your complications. So, Siva.
Mai from Cairo demonstrated a brilliant use of app technology, and I'd never thought of that, where you can ask your resident to send you a picture down the app and then help to decide what to do. This was a VSD that was non-existent to start with and got bigger as it went on.
But just a minute, Shaq. I feel for the resident because he was clearly colorblind. And so that absolves him from some of the criticism, surely.
So, round of applause for Mai. There was almost one clear winner, but the cheering has confused me a little bit. So by our reckoning, we're now down to two, a short list of two, and that is Roberto Mihangos and Hujat Mortazian. So now you're going to help us decide between the two. So high degree of incompetence, transeptal puncture without taking notice of your imaging guidance, and then closing the paravalvular leak with the help of image guidance. That was Roberto Mihangos. And reasonably good degree of incompetence with multiple stents that have a mind of their own, and that was Hujat Mortazian. You give him. Yeah. So Hujat, it's our pleasure to ask you to come up to the stage for something to be proud of. And Neil will give you the prize.
Hujat, that was a great presentation.
Thank you.
This is a coupon to be... Okay, sorry. This is a coupon that you can redeem for more stents.
Thank you. Thank you, everyone. Thank you, everyone. Thank you.
Okay, I think...
Finished
so
early.
we've finished a little bit early. We've got about 15 minutes break, I think, before we go on for the next session. Is that right, Z? Okay, stretch your legs and come back in 10 minutes. Thank you very much for that session to all the participants and speakers.